Today we have a returning guest with us on Brown Surgery Podcast, Dr. Eleanor Fallon, who's going to join us to discuss the informed consent process. You may remember that Dr. Fallon is a recent graduate of our Brown General Surgery Residency Program. She's now doing a transition to practice year, also known as a Mastery in General Surgery year, with us before she goes off to do her Surgical Oncology Fellowship at MD Anderson. So I'd like to welcome Dr. Eleanor Fallon back to the podcast today.
Great. Thank you for having me, Dr. Lynch.
So, Dr. Fallon, I'd just like to discuss the informed consent process a little bit today. It's a situation I think most clinicians, especially junior residents, find themselves in on a daily basis. And when we talk about obtaining informed consent from patients, I think that most of us would agree that for surgical consents to be valid, the patient must A, be competent to make that particular decision, B, have received sufficient information to make the decision, and C, not be acting under duress. I think there's a lot of parts, however, that go into that process, and I was hoping that Dr. Fallon could elaborate on that for us today.
Yes, thank you for that introduction, and I'm happy to review more in detail those kind of core concepts that you outlined and to expand on additional elements that are required for informed consent. So the first one that we'll touch upon is capacity, and this is different from competence, and it means the ability to decide for him or herself what the patient can make the decision. So when we talk about capacity, we want to make sure that the patient is oriented, that they're comfortable, that they're able to converse appropriately with you. Part of that includes having significant others available, having translators or any support available for the hearing impaired, so that the person is completely empowered to make the important decision of whether or not they want to give informed consent for a procedure or an operation. The next one we'll touch upon is voluntariness. The patient is not subject to coercion, undue persuasion, or manipulation, so they're feeling free and liberated to make the decision on their own and in a voluntary manner without any persuasion from the surgeon, the surgical team, or any surrounding practitioners or even family members. So you want to make sure that they're doing this for their own selves when they do have the prerequisite, as discussed, of capacity to make that decision for themselves. Another element is disclosure, and there are two sides of this disclosure coin. The first is reasonable patient standard, and the second is professional patient standard. So reasonable patient standard means that the physician must disclose what a reasonable patient would want to know in the same situation. And this seems a little bit vague, but it kind of gives a blanket statement of what the norm might be for a particular procedure, and that uses the physician's judgment of what they would want the patient to know in a similar scenario. And then for professional practice standard, this is just a disclosure based on the type and amount of information that other physicians disclose in a similar situation. So this one is a little bit more based on legal terminology. The next one we'll talk about is recommendation. So often we want to empower the patient to make the decision on their own, but it's okay for us as the practitioner and the healthcare provider to make a recommendation of what we would want for the patient. Everything has risks and benefits, operating, not operating, alternative procedures or operations to the one that's being proposed, and these should be outlined so that the patient can include your recommendation, but also the alternative treatments. The next core concept that we'll touch upon is understanding. So at minimum, patients should understand their diagnosis, the prognosis for that diagnosis, as well as the purpose of the proposed intervention, the risks, benefits, and alternatives to the intervention. So what we mean by that is a comprehensive review. We have a standard form on our computer that we kind of offer to everyone that includes kind of boilerplate information, but the importance here is communication with the patient to make sure that they understand what they'll be going through in as much way as we can make them able to understand. Next, we have the decision. The patient can rationally deliberate about the information presented and and make a decision that is in line with their goals and values. So this kind of builds upon the fact that they understand the information that you discussed with them and their family, and that they feel, again, empowered to make the decision of whether or not to move forward. And then finally, once they've made the decision, comes authorization. So that's the formal signing of the document. Sometimes that can be a verbal consent that needs to be documented separately in the case of an extenuating circumstance or an emergency. And that demonstrates that the patient has gone through all of these elements of the informed consent process, has made the decision to move forward with the operation with the understanding of the risk, benefits, and alternative proposed, and with the recommendation of the surgical practitioner.
Great, thanks for that review. I know some of this can be dry to go through at times, but those 7 elements should be understood by anyone approaching the informed consent process with patients. Breaking it down a little bit further, who should obtain informed consent? Obviously, there's a multitude of providers that see our patients on a daily basis. Should it be the junior intern? Should it be the senior? Should it be attendings getting informed consent?
So that's a great question, and it's a really interesting topic of ongoing discussion nationally of who obtains or who should obtain informed consent. And sometimes these answers are incongruous. Often the attending or the senior resident who may be the most involved in the intraoperative care of the patient during that said procedure is not the one actually obtaining the signature or the authorization from the patient for that procedure. So often the intern or junior resident is tasked with performing an informed consent discussion without having significant experience with that actual operation. And that's a difficult situation, and that's part of why we are working on a curriculum to equip interns with that skill set. But really a thorough understanding is required to appropriately advise the patient, and instruction on obtaining informed consent is really vital.
I think another question that also comes up is the timing around informed consent. Is it something that should be done immediately prior to a procedure? Should it be done days before, weeks before? Obviously, it's going to be different depending on office-based settings for elective procedures versus inpatient emergent procedures. But when you think about timing for informed consent, what's your recommendation for that?
Yeah, exactly. In an ideal scenario, you would want the informed consent process to be completed in a time and place that is remote from the operating room. So, as you mentioned, an elective procedure, the consent would be obtained in the office after a measured discussion with the attending provider who will be performing that procedure, with appropriate resources, either visual aids, language aids, and others, in addition to involvement of the family members or significant others to help make that decision, and the signature authorization can be done at that point. Often we're not in that scenario at all, where we're in urgent or emergent scenarios where we need to be obtaining informed consent immediately. In that situation, it's optimal to try to get the informed consent completed in the emergency room, for example, or in the patient's room before they're in the preoperative area. And the idea of this is that you're not rushing the patient, you're giving them time and resources to make this really important decision, and there's no element of coercion that they're already in the pre-op area, they've already gotten their IV, they've already been evaluated by anesthesia without an informed consent. There are certainly some caveats to that. Sometimes the document isn't scanned in from the office, and we often do kind of a cursory repeat of the informed consent process, but any time that you're doing that, please treat it as formally as possible. So even if the patient has heard it 10 times from the attending in the office, from the junior resident, the senior resident, everyone should repeat those risks and benefits, as well as the alternatives, recommendations, and all the other elements of the 7 core concepts we outlined, to ensure that there is no loss of information. So better safe than sorry in these scenarios. scenarios.
So when you talk about explaining a procedure to a patient, what should that procedure look like?
So the explanation of the procedure really varies upon the type of the procedure. It could be as so-called simple as an incision and drainage for a patient, or it could be as complex as an exploratory laparotomy for trauma, where you don't really know what you may find and what you may need to consent for. So taking into account the individual's experience in the operating room for those prior procedures will be helpful. A fifth-year resident who's done several hundred appendectomies can probably give a more nuanced explanation of the procedure than a fresh intern. And the importance of explaining the procedure will include how long the procedure may take, roughly the benefits and the risks of the procedure, which we'll elaborate on, but often the anatomy and the purpose of the procedure and what the core steps are. And visual aids can be great for this, as well as teach back or repeat back to try to allow the patient to say in their own words an encapsulation of what they understand. If there's any question, if the intern doesn't feel equipped to answer questions that the patient has about the procedure during the informed consent process, it's okay to pause and ask for help. Ask a senior resident on your team. Ask an APP or ask the attending directly. That's okay. It's better to have a comprehensive informed consent completed than have one done in a manner that's incomplete and can cause questions or concerns down the line.
I was wondering if you could just expand upon explanation of potential risks with a patient. Are there key components of that you should touch upon when you're obtaining consent?
Yes, that's a great question, and it ties in nicely with the explanation of the procedure, because I think an explanation of the risks goes along closely with what the procedure is and how sick the patient is. So in terms of general themes that we want to include, and I like to break it up into themes because it causes a lot of anxiety, I think, for the interns to be able to list every single small complication that may be in the realm of possibility for any of the number of subtypes of consents that they're obtaining. But the themes would be bleeding, infection, damage to surrounding structures, repeat admissions, and repeat operative versus procedural interventions, as well as, depending on how sick the patient may be, remaining intubated, being admitted to the ICU, having blood products transfused. So just to go into a little bit more detail, I always say bleeding, infection, damage to surrounding structures. Within the bleeding component, I always include a discussion of consent for blood product transfusion, or not consent for it, as the case may be with that patient, and making a note and a documentation of what the patient's preferences are. Infection is going to be very variable, again, on what you're treating. Perforated appendicitis versus an acute uncomplicated appendicitis, for example, within that contamination level has a variability of postoperative surgical site or deep space infections, and that's important to be equipped with that information before you go into a conversation. Damage to surrounding structures inherently is going to include the practitioner's understanding of the anatomy and the steps to the operation, which we touched upon in explanation of procedures. So if the practitioner doesn't understand that a CBD or common bile duct injury is a big risk in an acute cholecystitis case, that would pose a concern, versus someone who's done many of these cases, understands that, and is able to discuss that in an appropriate manner to the patient. That's really more preferred. And then we get into the critically ill patients, and I hope at that point the senior residents and the attendings, of course, are having those conversations as well. So even if they're not the ones standing at the computer with the signature pad and the patient, and the intern is doing that actual documentation, that there are many conversations going around that in addition to that document, and hopefully also written in significant event notes, etc., to support the whole concept of an informed consent rather than just having a formulaic document signed.
Great. I think in addition to talking about potential risks, it's important also to talk about potential benefits. Is that correct?
Yes, absolutely. And oftentimes we take this for granted because the patient may already be kind of on board with their diagnosis. They may be eager to hear what the surgical team has to say in terms of potential treatments that we can offer. But it's really important to review the benefits of the intervention and to decide in a joint way with the patient of whether these benefits outweigh the risks. So one of the tools that's been used for this is the best case, worst case scenario. And this kind of originated in the oncologic literature and has been expanded in the surgical consent literature for how can you frame a good postoperative course versus a complicated postoperative course as part of your informed consent, because it matters. So, best case scenario for a lap chole, you have a few incisions, they're small, you advance your diet, you have your pain controlled, and often you're going to be going home the next day, or even later that evening if you had a morning case, everything went well, and you're an otherwise healthy, active patient, and it was a uncomplicated, minimally inflamed intraoperative situation. Versus a worst case scenario where maybe the patient is a little bit more sick at baseline, or maybe you're suspicious that they had chronic component in addition to an acute component of their cholecystitis. Then you're a little bit more concerned about the level of inflammation. And of course, in all of the consents for a chole, you're going to talk about the conversion to open and what that may mean in terms of their postoperative care and course. But especially when you have a higher suspicion, it's important to lay that out, that they'll most likely have more pain, but that your team will be working on managing that they may be at high risk for a longer course of recovery in terms of heavy lifting and in terms of hospital stay, but that you're with them each step of the way to inform them regarding any alterations in what was laid out in the initial informed consent process. So although it is going to be a dynamic conversation based on what happens in the operating room, it's ideal to lay that out so they have some kind of expectation to work with.
Most folks, I think, especially junior residents, interns, don't realize that part of the consent process also includes an explanation of alternative treatments available for the patient and an explanation of the outcome if surgery wasn't to be performed. Can you elaborate on those two topics for us?
Yes, absolutely. And I think a lot of the time we don't end up emphasizing this when we're going through the informed consent process because those conversations may already have happened before we get to bringing over the computer or bringing over the pen and paper. But it's an important component. So in the outpatient setting, I think the alternatives are really extensively discussed between the attending surgeon, their team, and the patient with the patient's family member present. And often we're kind of focused on the risks, benefits of the chosen treatment route that we're going down. But it's always important, it is considered a component of the informed consent process in real time to look at what else could you do? Our institution was involved in the study looking at non-operative management of appendicitis in the pediatric population, and that's considered an alternative. But you also want to be equipped with why that might not be best for the patient if you've already decided with the surgical team and with previous conversations with the patient that the operation is the best route for everyone in that joint decision-making process of what we call informed consent. So although it's more nuanced, and because we think that most of those conversations happen before the form is signed, it's good to just touch upon it to make sure that the patient is aware of any non-operative interventions.
It's important to highlight here too, we're assuming the patients that we're obtaining consent on speak English as a primary language. I think when you're dealing with patients who don't speak English as a primary language, you have to take into consideration other factors, obviously bringing in a translator to have these discussions, but it can be especially important to bring in family members so everybody is on board with the process, addressing cultural considerations that these patients might have with the procedure, and also employing the teach-back method while you have a translator there to ensure that those patients understand exactly what they're going to undergo and their expected course of treatment.
Yeah, I agree 100%. I'm grateful that we're part of the PACS trial and curriculum where we're able to master those skills, but every day it remains a priority to make sure that people of different language, different culture, different health literacy and education are completely equipped to make what is often a really difficult and important decision in their life and in their families' lives.
Thank you for taking us through that informed consent process, Dr. Fallon. Just to summarize, what would you say are the take-home points you would like all of our residents, especially our juniors, to get out of this conversation?
The three things that I think are the most important to get out of this session are knowledge is power. The more you know about the procedure, the better informed consent that you can provide. You can better lay out the risks and benefits and have more solid communication with the patient. Ask for help if you don't understand the procedure or if you feel like you need additional clarification. There are team members to help you along the way. And then piggybacking off of this, communication is key. You want to establish a relationship with the patient, however brief that may be, it's still significant. If you don't feel like they understand something, they probably don't, and there are additional resources for you to obtain, whether it be language resources, visualization resources, and utilizing the teach back or repeat back method to gauge their understanding, and to even have other practitioners help you with informed consent if you feel like communication is lacking, or to be doing it in a different setting and hopefully remote in time and place from the operating room, so you're able to confidently move forward with the procedure knowing that your informed consent was as complete as possible.
Awesome. Well, I want to thank you again for taking the time to go through this process with us, Dr. Fallon. I think our residents, especially our interns, our APPs, are going to get a lot out of this. So thank you for the review.
Thank you.
For those of you who want further information on this, we can put some links down below to some of the resources that were used to formulate this discussion.
So thanks again to Dr. Eleanor Fallon for joining us today and discussing the informed consent process. If you have ideas or topics for further discussions on this podcast, please email me at kenneth_lynch@brown.edu. So thanks for listening, and we're looking forward to having you back with us in the next episode.